Good evening and welcome all. To celebrate the occasion of World Hypertension Day, Student Network Organization in association with Indian Society of Hypertension invites you this webinar session on management of hypertension. This webinar is digitally powered by Clarnet, which is India's largest live digital CME and doctor-generated medical content platform. So here is a short glimpse of Clarnet. Please allow me to share my screen. Thank you so much all for your patience. Now, I would like to hand over the session to Ms. Sakshi Lal ma'am for next proceedings. Ma'am, over to you.
Who cares if one more light goes off in a sky of a million stars? Who cares if someone's time runs out? Is the moment is all that we are? Yes, they do. Of course, I'm talking about the corona warriors, the doctors who day in and day out save the souls whose time is about to run out. Hello, everyone. These are tough times, challenging as well. I hope and wish each one of you is safe from this corona crisis. And to those suffering, don't worry, this too shall pass. Good evening. I, Sakshi Lal, along with my co-moderator, Shubhajeet Roy, welcome all of you to the webinar, all about the management of hypertension, organized by Students Network Organization, Uttar Pradesh, in association with the Indian Society of Hypertension on the occasion of World Hypertension Day. It's a wonderful day, and I feel privileged to extend my warm welcome to everyone present here. We have a very special guest with us, and it's going to be a very enlightening session. Let's see firstly what exactly SNO, the Student Network Organization, aims at. Independent organizing body within the network, TUFH, aims to increase the student participation and give career development opportunities through integrated participation in annual conferences and throughout the year through specific SNO activities. SNO is an autonomous body in official relationship with the World Health Organization, WHO, aims to create a platform for students of medicine and allied health sciences to dynamically engage in activity concerning public health issues. So before I start, I would like to thank Shashwat Sanket sir, the organizing chairperson, Anshali Adarsha, organizing co-chairperson, Dr. Komal Singh ma'am, organizing secretary, for taking this initiative and organizing this event on World Hypertension Day. I also welcome our esteemed guests from the national team. Dr. Prashant sir, National President SNO India, Lakhan Prakash sir, National Vice President SNO India, Dr. Rajneesh Raj sir, National General Secretary SNO India, Sakshi Singh ma'am, North Zone Coordinator SNO India. Now let's know what's in store for the session today. I request Shubhajeet to make us well acquainted with the same.
Thank you, Sakshi. Wishing our august audience for today a very good evening. I, Shubhajeet Roy, would like to introduce to you all a topic of discussion for today. As you all know, we are here today to have an interactive discussion on a very important yet alarming medical problem, hypertension. Such an important and global medical issue it has been in the past few years that today, the 17th of May, is observed as Hypertension Day worldwide. As India has transformed from an underdeveloped to a developing nation, non-communicable diseases like hypertension, diabetes, and obesity have taken the driver's seat of the most serious health issues of the nation, just like the Western world. So we being medicos should have a comprehensive knowledge about hypertension, its management and prevention, alongside the pathophysiological and pharmacological aspects lying behind hypertension. But most importantly, the implications that the current pandemic has had on hypertensive patients. So now I request Sakshi, my co-moderator, to introduce our esteemed speaker for today.
I really feel privileged to welcome respected Sir Dr. Narsingh Verma, Professor, Department of Physiology, Head of Department, Department of Family Medicine, King George's Medical University, Lucknow. Having been involved in teaching for more than 35 years, credited with more than 212 original publications, received 20 international and 26 national awards in the field of cardiovascular and metabolic research. Secretary General, Indian Society of Hypertension, President of Asia Pacific Society of Hypertension, and holding position in many of the medical associations globally. Respected Sir, we welcome you once again. Thank you so much for being here. We request you to enlighten us all with a few words of yours. Over to you, sir.
Thank you, Sakshi, and thank you, SNO, for giving me this opportunity to interact the most important work of my life, to interact with students. I think in the whole of my life of 62 years, this is most fascinating work assigned by the God to me. So I'm really very excited to talk and interact with you all. And you have chosen a very apt day, the World Hypertension Day. I think the rest of my life from last 10 years is dedicated to hypertension awareness and creating some good Indian data as well in regarding the hypertension. At present, I'm also working in relation with the Hope Asia, the organization which is working to create Indian and Asian data on the hypertension, because most of the time what we talk is European data or American data. We have to honor our Indian and Asian data.
Thank you so much for it, sir. The words mean a lot to us. We welcome you from the bottom of our hearts, sir. Thank you so much for joining us. It couldn't have been a better day for such a discussion than today, indeed. So let's begin.
A little housekeeping before we start. If you have any questions during the presentation, please feel free to use the chat box. It could be discussed at once the session is about to end. It's must for all the participants to fill up the post-presentation form.
Let's start with all that we have for today. Respected sir, should we proceed with the questions?
Yes.
So beginning first of all, what exactly is primary and secondary hypertension, and how and in which age do they have an effect respectively?
I think this is a very good question. And hypertension as such is basically divided into three types of hypertension. One, according to their cause, one is primary hypertension, second is secondary hypertension, and third is pregnancy-induced hypertension. So primary hypertension is basically term used to that hypertension which has multiple causes. No single cause can be ascertained. about the hypertension. It is polygenic in nature. Not a single gene is involved. A lot of genes are involved there. And usually it occurs at middle of the age. That is in India, 10-15 years before than the all over the world, but it's still from 25 to 40 years of age in my country. In other part of the world, it is later, that is 45-50 years of age. While secondary hypertension is that hypertension which is because of a particular cause. We know that cause. We can find out the cause. That cause may be the renal, that is renal hypertension, or endocrine, that is endocrinal hypertension, or cardiac, that is the heart is diseased and cardiac hypertension. Here we can find out the cause, but in primary hypertension, it is difficult to find out a single cause. It is multiple causes, and primary hypertension usually occurs in middle of age, while the secondary one usually is seen at the extreme of ages, either in the beginning, that is at the adolescent age group, or at the geriatric age group. Here, I will like to mention that age alone cannot be a criteria to classify the primary and secondary. Even at the adolescent hypertension, I am at present working on adolescent hypertension. We have been able to see that even in adolescent hypertension, primary is more common, secondary is less common. But if you overall compare, then the adolescent hypertension having in relation to adult one having more secondary hypertension. So age alone cannot be criteria. Even at the pediatric age group, essential hypertension can present, but usually the secondary hypertension is more common in adolescent and the pediatric age group. While the pregnancy-induced hypertension is a definite entity which is not related to either primary or secondary, it has its own origin and a different type of hypertension.
Thank you, sir. Now, a follow-up question to the same, that when it comes to ruling out hypertension in a patient, so is there a particular age beyond which a doctor looks out for secondary goals for hypertension?
This question is a very important question. Definitely. When hypertension is diagnosed at the pediatric age group or the adolescent age group, then definitely the doctor will like to look all the secondary hypertension causes. Like he like to investigate about the kidney and about the heart and also about the endocrinal disorders. While in the adult type of hypertension, he will be satisfied that it is basically having a genetic origin and the environmental factors, and probably the secondary causes may not be there. Again, at the extreme of age, that is in the geriatric age group, somebody was not having hypertension, and at age of 65, 70, he develops hypertension, then probably we have to look for the secondary causes again. So that is correct that age gives us an edge, that at particular age, we have to look more for the secondary causes.
Sure, sir. We should all have a regular checkup for sure. Moving forward, are the systolic and diastolic blood pressures dealt individually while treating a hypertensive patient? And do both of them have different effects on the body?
Very good question. And it belongs to physiology. You all know that the systolic hypertension is basically governed by the stroke volume and the cardiac output, which is the outcome of the stroke volume and heart rate. While the diastolic one is the outcome of the total peripheral resistance. So they have different type of origin. That is why both are important. But at younger age, we are more bothered about diastolic hypertension, because initially it is the diastolic one which rises, and then to compensate that rise in diastolic blood pressure, systolic has to rise. So below the age of 50 years, we are more bothered about the diastolic number, and more than 55 years of age, we are more bothered about the systolic number. Not only this, even the systolic blood pressure produces more harm to brain in the form of stroke, while the diastolic one is producing initial dearrangements in the cardiac function, producing diastolic dysfunction. So ultimately, the systolic also create problem for the heart, but initially it is more important for the stroke.
I think, sir, this piece of information would serve to be really helpful for us, the young medicos, while managing hypertensive patients. So now let's move on to the third question. Is it true that once a hypertension patient, always a hypertension patient? And what should be the most prevalent and preferred treatment in resistant hypertension?
Yeah, before that, we have to know what is resistant hypertension. Resistant hypertension definition involves that this is the hypertension where more than 3 drugs are used to control it. It may be controlled or not controlled. And out of these 3 drugs, 1 drug is diuretic. And all these 3 drugs have been used up to their maximum doses, maximum therapeutic doses. So if the hypertension is not controlled, even after using 3 drugs, one is the diuretic along with the other 2 drugs at their therapeutic doses, then it is called as resistant hypertension. Resistant hypertension again has a different pathophysiology. It involves another mechanism, that is because of the certain particular regions, this becomes resistant. But before labeling anybody resistant hypertension, we have to be very cautious about pseudo-resistant hypertension. What is this pseudo-resistant hypertension? In this particular pseudo-resistant hypertension, hypertension is not resistant. The patient is not compliant. The physician has written 2 drugs, 3 drugs, and up to the maximum doses, but the patient is not taking any one of them. So before labeling anybody as resistant hypertension, we have to inquire that whether he is not having the pseudo-resistant hypertension. Once it is found that it is resistant hypertension, even of the 3 drugs, 1 is diuretic and 2 others are at the optimum doses, the blood pressure control is not good, then it is of course resistant 1. Then we have to search for the causes of resistance. Causes of resistance can again be that the patient may not be taking adequate doses. And second, maybe the renal cause, which is the most important cause for the resistant hypertension. High renal activity. This again becomes an important cause. Sympathetic overdrive can again be an important cause. So we have to search for the cause, then we have to treat that particular cause. Till we are searching the cause, we have to increase the doses of drug up to their optimum level. And after that, the 4th drug is added, and that 4th drug is always aldosterone antagonist. That is spironolactone. Spironolactone has to be started at low dose from 25 milligram once a day and goes up to 50 milligram once a day. If it is not controlled, even after adding the spironolactone, of course, we will be trying to find out the cause of the resistant hypertension. But to manage hypertension, we have to add another drug, and that drug can be a beta blocker. And preferred beta blocker is the vasodilatory beta blocker. You know that beta blockers can become the vasodilatory beta blockers when we add a good beta blocker like carvedilol and the nivolol, which are vasodilatory beta blockers. So by this combination, most of the time blood pressure is controlled. But here I will like to mention one thing very emphatically, that is that first treatment of all hypertension, whether it is mild, moderate, severe, or it is stage 1, stage 2, or it is geriatric, adulthood and adolescent, pediatric, or it is pregnancy-induced hypertension, or it is resistant hypertension, the first treatment modality is always lifestyle intervention. Without addressing the lifestyle intervention techniques, nobody can start any drug. Along with drug, this lifestyle intervention technique has to be started. We have found that the lifestyle intervention alone can decrease blood pressure in the tune of 10 to 15 millimeter of mercury systolic and 5 to 10 millimeter mercury diastolic, which is not less than any drug effect. So this is the most important part of the management of hypertension.
Thank you, sir. So according to the guidelines set by the Government of India, we estimate approximately 48 million people with raised blood pressure. By the key points we just learned about the same, we could take precautions for sure. Moving towards the next question. When we relate lactating mothers and pregnancy, one of the most relevant questions is that does the mother continue breastfeeding even when she is severely hypertensive? And is she allowed to take medication? If she is, will the medication have any effect on the baby? Maybe like breast milk jaundice?
Again, a very good question. I admire the good question put by the SNO people. For pregnancy, we have different drugs, pregnancy-induced hypertension. But the problem is that the best drug which is used for pregnancy-induced hypertension become contraindicated in lactating mother. So most of the time, the pregnancy-induced hypertension, if it is pregnancy-induced, not the primary hypertension, it is treated by after the baby is born. Just after parturition, blood pressure becomes normal. In few cases, even after parturition, blood pressure becomes not normal and it is more than the normal value. Then of course, in lactating mother, we have to give treatment. And the good thing is that in lactating mother, a lot of drugs are available which can be given safely and which were not going to harm the breastfed child. And these drugs includes the RAS inhibitors, basically the ACE inhibitors, and the CCB, the calcium channel blockers. But only thing of caution here is even diuretics can be given in low doses. The caution here is that beta blockers are contraindicated in lactating mother. They should not be given. All beta blockers, including labetalol, cannot be given in lactating mother. Definitely, beta blockers will reduce the lactation and they will have adverse effects on the breastfed child as well. So only they are contraindicated. ACE inhibitors, CCBs, and diuretics can be given.
There has been a dramatic increase in the number of women breastfeeding during the last decade. Since little is known about the excretion of antihypertensive drugs into human breast milk, the management of hypertension during lactation can be problematical. So I think this vivid explanation by you would be very useful when our audience could be seeing to hypertensive lactating females in the world. So sir, let's move on to our fifth question. That how can hypertension be related to be present in a child? What measures and how frequently should we get a child tested? And can anxiety be one of the reasons?
Most intelligent question. I will say it is the most intelligent question. This area is most neglected area of hypertension. From 40 years back in USA, a committee was made to look after pediatric hypertension. And that committee recommended that in all pediatrics, every year or every third year, blood pressure has to be measured. But even after 40 years, the recommendations are not being followed. Pediatric hypertension and adolescent hypertension is not rare. In a meta-analysis published recently in 2020 from India only, it was found that the adolescent hypertension in India is in the range of 8%. 8%, and the range goes from 2% to 20%. In a study at Chennai, although the population was not much, but the total reviewed article which were included, various reviews were included, and various researchers were included, 25,000 cases. that came out to be 7.6%. But in Chennai alone, it goes up to 20%. In Lucknow, I have done a survey of around 10,000 students before lockdown. Of course, we would have crossed more than 50,000, but the lockdown has retarded it. The prevalence at Lucknow adolescent hypertension between the age group of 11 to 18, it was found to be 9.2%. 9.2%. And the most important factor all over the world, which were associated with adolescent hypertension, were the obesity, overweight. But contrary to this belief, in Lucknow, in our group study, which was done by our group only, has shown that even those who were not obese are having hypertension. And even those who are not having family history are developing hypertension. Then my group was amazed why it is happening. And here comes the answer. One of the hypotheses, we can't say it is 100% correct. It is a hypothesis that oversympathetic drive or sympathetic overdrive can be one reason. Why? Because in our society, the students of even nursery classes, KG classes, and primary classes, they are subjected to stress. And this stress is most of the time is poured by their parents. They compare that fellow parents' students are getting good marks and their people are not getting good marks. So that is one reason. This sympathetic overdrive in our children is harming. So stress has become a very important factor in Indian hypertension, especially adolescent hypertension. In all ages, stress plays a very, very important role. So according to the recommendation, every third year, blood pressure of all children should be measured. And in adolescent age group, every year, blood pressure has to be measured. But here, the values are not 120/80. In children's, we take the percentile. The less than 95 percentile, more than 90th percentile is taken as the value. If the values are more than 90th percentile, then definitely it is called as hypertension. Children's over the age of 13 years, the recommendation from the world authorities is that if the blood pressure values are more than 130/80, they are labeled as hypertension. If the children is more than 13 years of age. So by that, the hypertension in children's and adolescent age group is being diagnosed. Again, I will like to mention here, the primary hypertension is still more common in adolescent age group, but the secondary hypertension is comparatively more in comparison to adult one. So this is the level of the adolescent hypertension. Regarding treatment, the most important treatment modality in the adolescent hypertension is the lifestyle intervention. Even it's better than drug. And it is recommended that all those students, all those children, all those adolescents who have been diagnosed with hypertension, first 3 months, they should not be given any drug, and only lifestyle intervention should be tried. If it is not successful, then definitely the drugs have to be given. But before that, they had to be subjected to all the tests regarding the secondary hypertension to find out the cause. And the most important modality to confirm the diagnosis is ambulatory blood pressure monitoring.
Definitely, sir. A stitch in time saves 9. Frequently getting the child tested would decrease the rate for sure. The current lifestyle of the youth has made it all worse. A sedentary lifestyle is a need with no alternative, and with the lockdown for the past 1 year, has the country observed increased prevalence of hypertension in the younger population? What should be done to lie within the normal blood pressure range?
I think no study has been done clearly on this, but hypothetically you are very correct, because during this lockdown, most of the gym are closed, and youngsters are very prone and very they are having likeness for the gyms. So they are not able to exercise. And this is one of the reason that gives us idea that probably the hypertension is increasing. And they are more stressed in lockdown conditions. And during this particular period, they are experiencing more stress, not able to meet their friends physically. That is another stress they are facing. And even we are facing the stress, because I used to love the teaching in the class when the 250 students are sitting in the KGMU at Kalam Center. I used to walk from this corner to another corner and having my lecture physical. But at present, I'm sitting idle in a chair and talking to my students. This is not good for anyone. So probably you are very correct. The hypertension has increased up to some extent. But here I would like to mention one very important thing. Those who have suffered from COVID, they are also suffering from another problem, that is hypotension. Most of the COVID patients develop hypotension just because of dehydration, just because of lack of energy, just because of having fever, just because of having so many drugs. They are experiencing hypotension. They are also experiencing hypertension because of more diarrhea and having anorexia and lot of nausea, vomiting. They are developing hypotension as well.
So a follow-up question to the same. Propanol, better known as beta blocker tablets, are often taken to treat the undergoing anxiety. Can regular use of the same and maybe stopping it at once have an adverse effect on the blood pressure?
Propanolol, which is non-selective beta blocker. If you go by the pharmacology, non-selective beta blockers will have impact all the beta receptors everywhere, all over, and they are not selective for the beta 1 receptor. They will have impact both on beta 1 and beta 2. And because of that, basically the beta blocker non-selective like propanolol is given to take care of anxiety. Another indication for their use is the migraine, prophylaxis of migraine. They are also used, if you remember in pharmacology, they are also used for the prophylaxis of the varicose bleeding in the portal hypertension. So they have variety of uses, and propanolol have been a very safe drug and can be used for very long period. One side effect of this particular drug is that it increases chances of getting depression, number one. Number two, beta blockers, non-selective like propanolol, can increase the weight. These are the two side effects which are bound to occur with the long use of beta blocker like propanolol. Your question regarding whether it can be stopped all of a sudden, they will create a problem. Probably most of the problem they create is not related to hypertension. It is more related to mood, more related to anxiety, more related to other problems, not hypertension. They will not create hypertension. They will not precipitate hypertension, but they will create anxiety and depression.
Indeed, sir. This piece of information would not only be very helpful to our medical audience in treating patients, but also in building a healthy life for themselves. So let's move on to the seventh question, that over the past few years and more than ever in this coronavirus pandemic, the concept has been changing from office BP measurement to home monitoring. So like glucometers were promoted for diabetic patients. So will the BP gadget also become a day-to-day utility for a hypertensive patient?
Here I will like to blame my fellow professors. Due to their negligence, still in medical colleges, the blood pressure measurement is not taught as should be. You people are being taught in physiology that the blood pressure measurement is done by the direct and indirect methods. In indirect methods, you are taught about palpatory method and auscultatory method. But the most important is oscillatory method, which is not described during undergraduate days. And moreover, you people are not advised and not given this idea that use of the mercury is bad. And we cannot use mercury manometer nowadays. But still, in most of the medical colleges, most of the hospitals, still you will find a lot of mercury manometers, which is against the rule. And the concept has changed in last 10 years, I will say. The gold standard method of measurement of blood pressure by the mercury sphygmomanometer is gone. Now the gadgets are there, and these gadgets, which are electronic in nature, they are based on the oscillatory method of measurement of blood pressure. And the basic difference is that in mercury manometer, we find out systolic and diastolic, and then by calculating, we calculate the mean arterial pressure. But in oscillatory method, it is the mean arterial pressure which is measured, and systolic and diastolic has to be taken out of that. So that is one difference. Second, that the oscillatory method is a better one because each oscillation has its own amplitude, and it is the beginning of the maximum oscillation is the systolic one, and the lowest one is the diastolic one. Third thing, that in the manual method versus the monitors or electronic gadgets, the difference is that in manual method, whether we are using the mercury manometer or we are using LED manometer, in all these there's a problem that most of the time observer has a driving seat. If the observer wishes to say it is 140 or 130, he can do. But in the gadgets and monitors, which are electronic one, it cannot be possible. So most of the problems which are the operator based are gone. The biasness of the operator is not there. Moreover, the manual method has one more problem, that the most of the time with age, the auditory functions are compromised, and the senior physicians may not be able to listen any sound. The corotocop sounds may not be heard, and the blood pressure measured may be wrong. So today's word is knowing that the oscillometric method monitors or the electronic monitors are the method which is not manual method, which is the automated method, is the best one. Now coming to the office measurement versus the home measurement versus the ABPM. There are three methods to measure blood pressure. One is the office measurement, that is in clinic. Problem in clinic is that when a doctor or the medical worker is measuring blood pressure, most of the time it produces a lot of white coat effect. And due to white coat effect, blood pressure measurement becomes faulty. Second thing is that masked hypertension is totally missed by the office measurement. So all over the world and in the Asia, especially the data from Japan and Korea and China have proved that home monitoring is the best method of measurement of blood pressure. Because in home monitoring, we can reduce the white coat effect, and we can also diagnose the masked hypertension. What is white coat effect? White coat effect is that in room of the doctor, in the clinic of the doctor, blood pressure of the person goes high just because having more sympathetic drive. But at home, at ease, when he's measuring himself or a relative is measuring, the blood pressure becomes normal. This is white coat effect. And what is masked hypertension? In clinic, the blood pressure is normal, and at home, it is very high. It is masked hypertension. These people are having a different type of attitude. They think that they are in the clinic of doctor and they don't have to worry, and their pressure goes down. But at the home, their pressure goes up. So this is masked hypertension, difficult to diagnose by the manual method. It can only be diagnosed by the home monitoring. So the gold standard today is ambulatory blood pressure monitoring. I am working in the field of ambulatory blood pressure monitoring from last 15 years. I have the maximum number of data in India of ABPM, and I have my own data of 7-day data of blood pressure monitoring. And ABPM, best ABPM is done from Monday to Sunday. That every day the blood pressure distribution will be different. And the Monday cannot be Tuesday, and Wednesday cannot be Friday. So every day the blood pressure will be different. But it is difficult to do ABPM for 7 days. So usually 24-hour, 48-hour data is done. Home monitoring is a good replacement. 2 readings in the morning just after getting out of the bed and 2 readings in the evening just before going to bed are enough for 7 days. This can diagnose most of the problem, and it has also been seen that those patients who do home monitoring, they are more compliant to their treatment because they are measuring their blood pressure. So the drugs, they are more compliant to the drugs. So you are very correct that in Corona time, COVID times, it is home monitoring become more prevalent. But even if the COVID times are not there, home monitoring is the best method one can have, and we have to propagate that. And you are very correct in saying that like glucometer in every home, similarly like thermometer in every home, glucometer in every home, and now pulse oximeter in every home. We must have a good quality BP monitor at every home.
So now a follow-up question to the same, that if a patient home monitors himself and has persistently seen his or her BP on the higher side, moreover, he has also experienced symptoms like dizziness, headache. So before diagnosing the patient with hypertension, what are the routine investigations that you think must be conducted?
Once you want to diagnose the hypertension and patient has been given a monitor for the home monitoring, few things are very important. They are how to take measurement of blood pressure. There are certain prerequisites, like before measuring blood pressure, half an hour before, one had not taken coffee, tea, alcohol, tobacco, etc. Even any cardiac stimulant drug should not be taken half an hour before. Second, the bladder should be widened. Full bladder blood pressure will be different. And the belt of the person had to be removed, or it had to be relaxed. And the person should sit on a chair and back is resting. Back is resting, foot are lying on the on the floor and not hanging in the air. Not only that, he's sitting comfortably and having foot placed on the floor and back rested on the chair. And then the cuff should be, the size of the cuff should be optimum. That is, the person, if he's obese, oversized cuffs are required. So we have 5 sizes of cuff: children's, normal size, less than normal, more than normal, above size. So 5 sizes of cuffs are available. The size is decided on the basis that the cuff should encircle at least 2/3 of the arm circumference, and the brachial artery should be in middle of that. After this, when the cuff and everything has been settled, the blood pressure measurement should be done. And this should be done in the early morning, just after getting out of the bed, after widening the bladder. And the legs should not be crossed, because crossing the leg and talking with the patient will have a definite different type of the things. Then the cuff should not be very tight or very loose. If it is very tight, then the blood pressure measured will be less than the normal blood pressure which he has. And if it is loose, then the blood pressure readings will be high, not having the normal blood pressure. So after this, the training is required. The person should be trained that how he is going to measure blood pressure. Then he is asked to measure it morning, evening, 2 times on each day for 7 days. If all the 7-day readings after computation, you can see they are high enough, then the diagnosis of the hypertension is made. Now you have to give treatment. But before treating, as you said, you will like to have some baseline investigations. Here, I will like to say one thing, that today's world is full of investigations. A lot of investigations are there. It has become very difficult to find out the required investigations, because a battery of investigations are already there. But what are the investigations, minimum investigations which are required are a good ECG. A good ECG is required at the baseline, and CBC, definitely CBC is required, and the lipid profile is required. Serum creatinine, blood urea, and blood urea nitrogen is required. These few tests are must before the start of the drug is done, just for a baseline value, and then the drug is started. Before drug is started, lifestyle intervention has to be explained in detail.
Definitely, sir. COVID has changed it all, be it the diagnosis, treatment, or the methodologies. When we are talking about COVID, let's know what's the most frequently asked query. Does the medication for hypertension, like ACE inhibitors or angiotensin receptor blockers, affect COVID infection and its related mortality?
This question is again very important because this controversy started when it was known that the COVID virus is going into the lungs via this particular receptor, ACE2 receptor. And after that, this controversy came that by inhibiting the ACE inhibitor, whether we will harm to the patient. But later on it was proved that this all depends upon the number of receptors and their activity. So at present, what we have, the consensus is that ACE inhibitors are not harmful and they should be continued. The most of the organization in the world, including the International Society of Hypertension and the American Heart Association and the European Society of Hypertension, are of view that the ACE inhibitor should not be stopped and they are not harmful in the patients of COVID. But if the hypertension was not present since before COVID, during COVID the hypertension has started, then definitely the CCBs can be a better choice. We should not go for the ACE inhibitors.
Thank you, sir. I think this beautiful answer of yours could have answered the curious brains of our audience, who must have surely read about the role of ACE2 receptors in COVID pathogenesis and must have tried to find the link with the antihypertensive ACE inhibitors. So, sir, let's move on to now towards the audience questions.
Yeah.
And the first question, someone has asked that he wants to know about postpartum preeclampsia. Is the new mother still at risk even after the baby is born? And if she is, what effects does it have on the body and what precautions should be taken?
I will search this question because okay. Can you repeat the question?
Yes, sure.
Can you repeat it?
Yes. Is the new mother still at risk even after the baby is born? And if she is, what effects does it have on the body and what precautions should be taken? This is with respect to postpartum preeclampsia.
Okay, good. That's a very good question. Actually, before that, we have to understand what is difference between pregnancy-induced hypertension, preeclampsia, and eclampsia. Pregnancy-induced hypertension is the hypertension during pregnancy, especially after the first trimester. In second trimester and third trimester, the hypertension is diagnosed. This is pregnancy-induced hypertension. But if this pregnancy-induced hypertension has the albuminuria, this is preeclampsia. And if the patient is having hypertension, albuminuria, and also having convulsions, that is eclampsia. So the post effect, that is most of the time what happens in preeclampsia and eclampsia, it is very, very difficult to complete the pregnancy because this is called as toxemia of pregnancy. And most of the time it is harmful for the mother as well as for the fetus. But anyhow, it is completed, then definitely the harmful effects are seen on the fetus as well, that is the children as well, or the born baby as well, and in the mothers as well. both are having the complications in relation to cardiovascular complications. That is why it is very catch-22 position whether to continue pregnancy when it is having eclampsia or not. Most of the time it is not completed, but even if it is completed, it has a lot of complications. You are very correct.
Thank you, sir, for the answer. Would now like to move on another question, that what kind of complication does a baby has to face if he is suffering from pediatric hypertension and if it's ignored and not monitored?
Okay. In pediatric hypertension, if it is not diagnosed, then the most important effect will occur. That will be on the cardiovascular system. And it has been seen that the lot of cardiac complication in the form of left ventricular hypertrophy and even left ventricular failure can happen. This has been seen that the one prognostic factor can be a good 2D echocardiography. By that, we can diagnose the this particular increase in the left ventricular hypertrophy and left ventricular failure early. So this is the one effect one can have. Definitely the second one will be on the kidneys, and the kidney can go into chronic kidney disease, and even the acute renal failure can ensue. So these two organs are affected most, the heart and the kidney.
Now a reminder, it's must for all the participants to fill the post-presentation form that has been provided in the chat box. Now towards audience third question. Sir, long-term research studies have demonstrated that high blood pressure in midlife is a key factor that can increase your risk of developing dementia in later life. So is it true?
This is most important question, I will say. And I will like to answer with a story. I was invited to Japan. A senior professor at Japan University invited me, and Japan University gave me the travel grant. When I went, I found that in every hypertensive individual, when they were diagnosed first time having hypertension, all the patients were subjected to MRI. I asked that why, professor, you are doing MRI to all patients? Then he showed me that, gentlemen, see this MRI. The person is only 45-year-old and first time diagnosed as hypertension. But in MRI, the minor lacunar infarcts are seen. So all these patients, if we see the lacunar infarct, they will definitely develop into dementia. So if the hypertension is not diagnosed early, it is diagnosed late, the dementia already ensues. So dementia is one of the major problems one will face if the diagnosis of hypertension is not made and not treated properly. We have to educate our patient that if you are not taking your drug regularly, you will definitely go into dementia.
Thank you so much, sir, for answering our audience questions so patiently. Now, sir, it would be very nice if you could address the take-home message for the audience who have attended this session.
Good. My take-home message is that please, in all NCDs, consider hypertension the most important. In India, 35 to 40% individuals are suffering from hypertension. And in your life, give more time to measure blood pressure at once only to your patient. Because if you are not measuring yourself, you are dependent upon the reading of others, that will not suffice. And please go through the guidelines of the International Society of Hypertension and American Heart Association regarding good measurement practices of the blood pressure measurement. They are very nice and you have to learn a lot. So my advice is that please give attention to hypertension. This is not simple drug, simple disease. It is very, very complex. And the measurement of blood pressure is a clinical soft thing which you have to learn very aptly and utilize in your life. Thank you very much.
Thank you so much, sir, for sparing time for us from an extremely busy schedule in the midst of the second wave of the COVID-19 pandemic. It was an immense honor and pleasure to host you today. And I'm sure our audience must have gained a lot from this enlightening session.
Now, may I request Lakhan Prakash sir to say a few words about today's session?
Hello, Sakshi, am I audible?
Yes, sir.
Okay. Good evening, sir, and hello, everyone. So, on behalf of SNA India, I would like to first of all congratulate the whole SNO Uttar Pradesh team for their very first webinar. Webinar. Also, I thank Dr. Narsingh Verma sir and Indian Society for Hypertension for their words and collaboration with SNO. Also, as today is World Hypertension Day, as we all know, we can see a lot of young medicals are also dealing with hypertension situation in this current stressful environment. Hope you have had noted quite noted all the words from the speaker, sir. At last, no event is possible without the audience. Hence, thankful for being amazing. And personally, I would say, sir, it was a very knowledgeable and informative session. Thank you so much, sir.
Thank you. Thank you.
Thank you so much, sir. Your words really means a lot. One time more reminder, it is must for all the participants, all the attendees to fill the post-presentation form in order to avail your e-certificates.
Thank you once again. And with this, we come to the end of this wonderful session. I'd like to mention our coordinators, Pavani Goel, Shruti Shalini, Shashwat Singh, Muhammad Intikhab, Auras Katiyar, Mariam Rauf, and Ikshita Nagar for ensuring smooth conduct of this event. I would like to end this session by reinstating the theme of the 2021 World Hypertension Day. Measure your blood pressure accurately, control it, live longer. And whoever has listened to Sir's words today knows to do them all. This is SNO UP team signing off. Thank you so much once again.
Thank you.
Thank you.
Thank you.
Thanks to the audience also for joining in. You can now leave the room. Thank you so much for joining.
Thank you all. I'm closing for today. Thank you.